listening to Kansas Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is August 21st, 2023. Our topic is the clinical guidelines for management of eosinophilic esophagitis. Our presenter is Dr. Mathew Rank. He is a professor of medicine at the Mayo Clinic and the division chair of allergy, asthma, and clinical immunology at the Mayo Clinic in Phoenix, Arizona.
Right. So welcome everybody to Conferences Online and Allergy, coming to you from Kansas City today. It's August 21st, and I'd like to welcome our first speaker, who is Dr. Mathew Rank. He's an allergy immunology physician at Mayo Clinic in Arizona. He's professor of medicine at the Mayo Clinic Alex School of Medicine, and he's also division chair of allergy, asthma, and clinical immunology. He served on the Allergy Immunology Joint Task Force group for the practice parameters since 2016. And he is here today to speak to us on eosinophilic esophagitis. Thank you.
Great. Thanks a lot, Dr. Miller. Welcome, everybody. That last bit, service on the practice parameters team, I think is what led to this invitation, and I'm grateful for that invitation. I'm going to talk primarily about a guideline that I worked on with the Joint Task Force and also with the AGA, the American Gastroenterological Society. So our GI colleagues teamed up on a parameter on management of eosinophilic esophagitis. And I'm going to say EoE for eosinophilic esophagitis during this talk for everybody who may not be familiar with that abbreviation. I wanted to start by saying a couple things up front about conflicts of interest. I'm employed by Mayo Clinic and also Phoenix Children's Hospital. I'm involved in the practice parameters, which is probably, again, the reason I'm giving this talk. And I'm also involved in both the college and the academy and the breathmobile that we have in Phoenix. I have 3 current research funding sources. The first 2 are related to asthma, and the second one is related to food allergy and not closely related to any of the management options for EoE. I also wanted to make a mention that up until recently, there weren't any FDA-approved management options for eosinophilic esophagitis, and when we did this parameter in 2020, there were none, and therefore, I will be speaking about interventions for EoE that are not on label. I'd also like to acknowledge the people that did the work on this parameter alongside me. You'll see them listed here: Dr. Acevis, Dr. Chan, Dr. Dellin, Dr. Falketer, Faruda, Greenhout, Hirano, Sharaf, Spergel, Stolman, Stukas, and Wang. Those folks made up our work group. These are the folks that looked at all the evidence and wrote up the various reports, and then also our JTF members who weren't involved directly as work group members, but provided oversight, insight, critical reviews, and those include Drs. Bernstein, Dinakar, Golden, Kahn, Lieberman, Oppenheimer, Shaker, Wallace, and Wang. So credit to all those folks for building this out. I have 4 learning objectives for this morning. The first is to explain how we use this grade method to make recommendations for multiple different EoE management questions in the parameter that was published in 2020. The second is to summarize the recommendations and show how the evidence profile informed the final clinical guideline recommendation. The third is to try to bring this home to practice. Well, the third and fourth really both are. The third is to describe how we, as allergy immunology doctors, can use these guidelines to help our patients. And then the final thing is to provide some additional context for 2023 and think about how the new research in the last 3 years after our publication may change how we think about management of EoE. I'm going to be pretty short with the background information about EoE. I think this is a common enough problem with estimated prevalence of 1 in 2,000 that most of the people listing in allergy immunology fellows have seen children or adults with EoE, have considered how to make this diagnosis and considered some of these management options. I am going to remind you that EoE can present with different symptoms, different ways that esophageal dysfunction can manifest, including dysphagia, food impaction, failure to thrive, especially in the youngest children, nausea, vomiting, abdominal pain, reflux symptoms. So it's not all the same when we're seeing these folks in clinic. There is a gold standard that has been put forward based on histology of counting eosinophils in tissue of greater than 15 eosinophils per high power field counted as a diagnostic criteria. We'll talk a little bit more about that when we were working on our guideline and trying to decide which outcomes to focus on. The other important thing to keep in mind is that the symptoms that patients have and the objective findings don't necessarily associate every single time. And then the other important thing to remember is that the course of EoE for a patient is usually chronic with some waxing and waning over time. I'm going to start with an overview here. This was a diagram that we put together with AGA, really driven by some of the artists and others that work with AGA to try to put a single slide that summarizes an overall management approach. Now, this was difficult to do, required many rounds of review, many opinions among the work group members and JTF members in order to try to show that one management option over another may not be obvious for most patients. So this is the overview. So if somebody has a suspicion, clinical suspicion for EoE, one of the things we want to remind people in the diagnosis part is that there can be other causes of eosinophilia in the esophagus, and those causes should be considered. Then, if we're on the left part of this algorithm, where it says eosinophilic esophagitis, and that's kind of what we think is happening, there are arrow options to medical and diet therapy, neither of which is favored necessarily over the other. The medical therapy options, PPI, so proton pump inhibitor, and TCS stands for topical corticosteroid. And then the diet therapy, there are options within the diet therapy, which could include empiric elimination, as we'll show. It could be 1 food, 2 foods, 4 foods, 6 foods. It could be elemental, and there could be allergy testing directed diet therapies. And then there's a dotted line when when we find there may be clinically relevant stricture in the esophagus, where esophageal dilation could be considered. And then there's response, non-response, shifting between these different options, and then all leads to a maintenance therapy plan. So this is the overview, and this is sort of one of the end products of what we tried to disseminate as part of our project. Now I'm going to get back into the details. So when we try to answer a question for our guideline team, we start with a question. And it's really important that the question's important, that it matters to people who practice medicine, practice allergy immunology in particular, and that it's specific enough that we can go into the literature and do our best to try to answer it. And so we use this format generally, the PICO format, the population, intervention, comparator, outcome. You'll see this in most of the guidelines Joint Task Force has released that are using the grade method, where we ask a specific question, use specific methods to identify all the information about that particular question, and then judge the evidence as we go through. I want to pause a minute and talk about the outcomes, because I think this is really important, and one of the challenges that we had in our work group. So what we do before we even start looking for the evidence is we have a discussion about which outcomes we're going to prioritize, and we rate them as critical, important, or non-important. We try to get a broad list of outcomes that could be considered, and then go through a process where each person independently rates how important they think these outcomes are for our patients. And importantly, for this guideline, the work group selected histology, so the number of eosinophils per high power field, or more specifically, a cut point above 15 as being the most important and critical, the critical outcome, which really drove a lot of the recommendations. And there are other outcomes, particularly patient symptoms, progression, stricture, impaction. There are other things we could have considered, but this was what was selected. So I'm going to talk about some of the other outcomes and how they were rated. Here's the histology definition and less than 15 per high power field was considered a successful management. It was considered remission of disease. Symptoms, which could be measured with all of these different questionnaires that are available, was considered important. Endoscopic findings were considered important. Complications of EoE, mentioned some of these: stricture, impaction, malnutrition, some of the psychiatric impacts of having this disease were considered critical. Quality of life was considered important using some different questionnaires. And then biomarkers were determined to be not important, far enough away from patient-important outcomes. Adverse effects of whatever we were doing were thought to be important. So if we eliminate a food and then they ultimately develop an allergy, if we affect how their weight is, if we cause anaphylaxis, those types of adverse effects, and then specific adverse effects, complications of endoscopy when we're considering performing endoscopy for either diagnosis or for dilation. And then costs were considered important as well. So next we went to the literature and tried to find every single bit of information that we could find. Not only do we look in the published literature, we try to find the so-called gray literature, where something might be out there but not indexed, where something might be submitted to the FDA but never submitted for publication, where there may be missing information that we can get by contacting an author. And our goals were to reduce the chances that we're missing anything important. Then we take all that information, synthesize it into forest plots and evidence profiles, and then we have our clinical and methods experts review this information to make sure we have it right. And then we prepare a technical report with all this information. The technical report is basically the evidence. Then the evidence is sort of consumed by the writing group, the guideline writing group, and then the guideline writing group takes that and makes clinical recommendations for all of us for our practice. These are some of the options we have when we're working in the guideline writing group. We can make a strong recommendation. And so when we make a strong recommendation, we use language like, we recommend this intervention for this condition. What that means for the patient is that just about every patient is going to want this recommendation, only a very small proportion may not. And then what it means for the clinician is that most of the time we should be recommending this. In fact, it's probably such a strong recommendation that if we're not doing this, we may not be meeting sort of the quality benchmarks that we might expect to achieve as a practicing doctor. It also means that having a lot of discussion about different options may not make a lot of sense. It's pretty clear this is what should be done. There's not a lot of time spent in sort of this shared decision-making time that I'll talk about in a little bit later here. When the evidence is less certain, when the effects may not be as large, when there may be safety concerns, then sometimes those recommendations then become suggestions and they become conditional recommendations. That means that the majority of individuals would still want this, but many would not. That means that for us, when we're talking to patients, different choices mean different decisions for different patients. And some of the things that go into shared decision making, considering patients' preferences, patients' values, considering context, can really make a big difference to the ultimate decision. And these are the pretty self-explanatory levels of confidence in the evidence. A high rating. We're very confident that this is the estimate of effect. It's unlikely to be anything different. It's unlikely that more research is going to change this estimate. Moderately confident means we're probably pretty close and in the ballpark, but it's a possibility that some new research could come along and substantially change this point estimate and ultimately then the recommendation we make to a patient. Low, this is just limited confidence, and very low is we have no really great idea what the estimate is likely to be. It's a pretty big estimate because the features of the literature just make this uncertain. Okay, so that's the first part. The first learning objective was to get a sense for how this grade method system is set up again. And I know this is probably a bit repetitive for those of you who've listened to other COLA lectures about other guidelines, but I think it's important that we're all on the same page when we look at these specific recommendations, which is what we'll do next. So there are several of these. I'm going to read them and allow us to kind of reflect on them. And then we're going to go back to synthesize again about what we would do as allergists with some of this information. I'm also going to spend a little bit time for a couple of the recommendations, showing you some of the more raw evidence that we used, and hopefully help you understand why we arrived at the recommendation we did. So the first recommendation is, in patients with symptomatic esophageal eosinophilia, our team suggests, which is the language for conditional, using PPI over no treatment. Now, in this case, we didn't say EoE, we said symptomatic esophageal eosinophilia, because around 2020 and 2019, when we were putting this together, there was kind of some controversy about this concept that was called sort of PPI responsive esophageal eosinophilia. And there were some questions about whether that was really different from EoE. I think as additional research and additional information came in, more of us are thinking that this is really an EoE type and not categorizing it differently. So I think if we were to redo these guidelines in 2 years, we probably would list this as EoE rather than this other term. So this recommendation is conditional, and this is very low quality evidence. And I want you just to think about this a bit, because I think, at least in our practice and from talking to other people, using a PPI for EoE is often the first line treatment that's selected for a variety of reasons. And the quality of evidence for that choice in 2020 and still in 2023 likely is very low quality, very low confidence and certainty in that evidence. Second recommendation is a recommendation for topical glucocorticoids over no treatments. This is moderate quality of evidence, and this turned out to be our only strong recommendation for the guideline. The third is to suggest topical glucocorticoids rather than oral, and this is conditional based on moderate. The fourth recommendation is get into diet, and this is a suggestion for elemental diet over no treatment, and the quality of evidence is moderate, and again, this is a suggestion or a conditional recommendation. And sometimes when we do conditional recommendations, when there's a very clear context to consider, we'll add that as a comment right into the main statement. And here, the comment ended up reading that people, patients, families who put a higher value on avoiding the challenges of adherence to an elemental diet and the prolonged process of dietary reintroduction may reasonably decline this option. And then we get into some of the empiric diets. In particular, we focused on 6 food where there was the most information, low quality of evidence, suggestion, conditional recommendation. And here again, we have a statement about the challenges and difficulties with diet therapy. Finally, we talk about allergy testing based elimination diet, and the quality for this evidence is very low. The recommendation is a conditional one. And this is an important comment that I think we really many in the work group felt strongly about and important to consider, which was that the accuracy of the currently available testing for identification of food triggers for EoE is limited, and patients, families may prefer either empiric or alternative medical treatment to taking this approach. Here's one statement about maintenance therapy, and this is patients who have relief after a short-term course of topical steroid. Our team suggested continuation over discontinuation. The evidence here is very low quality. And then the value statement is valuing the control of disease versus the potential long-term risk of using topical steroid. Our 8th statement was in patients, adult patients. We didn't make any comments on pediatric patients who have dysphagia from a stricture. We suggested dilation over no dilation. The quality of evidence for this is very low, and the strength of recommendation is conditional. Our 9th recommendation, and really the subsequent recommendation statements here, are getting into situations where we had questions about these different interventions and ultimately found very little evidence for or against, and therefore have a number of knowledge gap statements here. So the first knowledge gap statement is related to anti-IL-5 therapy for EoE. And when we have a knowledge gap like this, we state patients may think about taking these treatments, but probably best, or we think best in the context of a clinical trial. We actually made the same statement about anti-IL-4 receptor therapy in 2020, and we'll review how that's changed since 2023 in a couple slides here. And then we had a few other statements. This one was maybe a little bit more interesting because this was a conditional recommendation against anti-IgE therapy. There was a trial that suggested that anti-IgE therapy had pretty little effects in EoE, so we made a conditional suggestion against, but also that conditional recommendation against was very low quality evidence. Finally, there were several other treatments, including montelukast, cromolyn, a few different immunomodulators, and anti-TNF, for which we made no recommendation and suggested only taking in the context of a trial. As I said, I wanted to show you just a little bit more information about the PPI and the topical steroid evidence profiles to give you a sense for what we are looking at. So this is the evidence profile for PPI. These are the different studies, author and year, and these are the summary of the information here. So the number of participants were about 1,000 or so, and these were all observational studies that were included. And the outcome we selected for this was not achieving histologic remission, so basically failure of controlling disease. The relative risk of failing to control was lower, which means that PPI was presumably helpful in controlling disease. The relative risk of doing this was 0.66, and the risk difference, the absolute anticipated effects, were about 295 fewer people failed to achieve remission. So that's about 30% more achieved remission if they were taking PPI. And this is the evidence profile here that says very low. And part of what informed this very low were first, these are observational studies. So our confidence without randomization, without prospective trial becomes lower. And in this case, you can see on our forest plot where we map out the estimates of effect using our proportion, it's really, really varied. And when we see variance like this, we get really concerned that the treatment effect is difficult to estimate. So this is the summary at the bottom here, this light blue diamond, but all these boxes could be 0.8, another box could be 0.1, and we just didn't have a very good sense. And we looked at all these studies individually to see, was there something about them that maybe all of these ones that are over here on the right are similar in, and the ones on the left are different in. And there was no obvious reason that we could identify for this huge variance, which led to rating the evidence down to lower. This is a little bit different, and this is why the topical steroids received a stronger recommendation than the PPI. In this case, we were able to look at randomized trials. There were 8 of them. A little over 400 patients were enrolled in these trials. We rated the certainty of the evidence as moderate. The relative risk was even a little bit better. It was 0.39, and about 500 patients out of the 1,000 on an absolute effect would have achieved remission if they used this treatment versus if they hadn't. So these and then the forest plot, if we're looking at the risk ratio here, it's a lot more consistent. It's really all within this sort of 0.29, 0.38. It's a little bit, it was more consistent and allowed us to be more confident about our point estimate of treatment effect. So that's just a little bit about 2 of those. I'm going to remind us that the vast majority of the recommendations we made for this parameter, for this EoE management parameter, and by the way, the vast majority of recommendations we make for most of the parameters I've been involved with over the last 7 years or so, are conditional, because the evidence isn't strong enough for us to say just about every person who has this condition should take this treatment, and there's really not much to discuss. I think those of you who spent time in the room with patients and families who have EoE realize that it's a discussion about all these different options that usually is taking place, because there's not a single piece of guideline recommendation that we can give that says you should do this for everybody and everything else is kind of an afterthought. even with that recommendation that we made for the topical steroid, that strong recommendation, you can see that our recommendations on how to use this information still call for discussion and shared decision making. And I highlight this again in red, and this is the message I've given at the various annual meetings and other meetings where I've presented on this guideline, is that when you have somebody on your schedule who wants to talk about management of EoE, think about spending a little bit more time with them to really get towards a quality decision. Okay, we've gotten to the first two parts. We talked about the methods. We talked about the evidence profiles that informed some of the clinical guidelines. Now I want to talk about synthesis, and then we'll talk about some additional context since 2020. So as a practicing allergy immunology doctor, I have this information with a whole bunch of conditional recommendations, one strong recommendation. Does that mean that I should just tell everybody to take topical steroids and everything else should be, maybe considered later if topical steroids fail? And that's not, remember, what our algorithm showed, our synthesis algorithm. It showed medical options, PPI, topical steroids, dietary options, both as reasonable first-line options to consider. Decision aids, which are things that put information in a way that makes it easier for patients to understand and for us to discuss information with patients, may be helpful for EoE. To my knowledge, there's not a decision aid that's currently available for EoE that's been tested or published, at least. I know there's some in process, but this could be something that could potentially be useful. But again, the bottom line is, when we're sorting these options with our patients, we should expect to spend a little bit more time. Now, I've thrown this word around a little bit. I'd be surprised if almost everybody listening into this to this seminar hasn't heard this term before. We talk about it a lot in our practice parameters, and the term is shared decision making. I teach this in our medical school. I evaluate our students performing this type of interaction, and I've learned quite a bit from that educational participation. And one of the things I would first start by saying is there's a lot of talk about shared decision making. There's maybe not a lot of information out there, at least in our allergy literature, about how to do shared decision making. They're saying do shared decision making. This article by Dr. Blaise from 2019 in Annals of Allergy is probably the best place to start about background information on this concept and how it relates to allergy immunology. However, even this excellent article may not go into some of the details about how to actually perform shared decision making. And I'm going to give you just a very distilled message about shared decision making that I've taken from teaching it to medical students for the past 10 years. And the first part is maybe the most important, which really is setting the stage for your patients and families to make sure you're inviting their values, preferences, their important context by giving a preface and saying, we have some different options. I want to work with you, hear about what some of the things that you think are important to try to decide what the best option is going to be for you. So making that introduction, allowing that space for patients to have their voice heard, then listening as they share some of that information, and then synthesizing that information into the ultimate decision. Those are the three main steps that involve shared decision making. That could take a minute. We teach the 1 to 2 minute shared decision making tools that the family medicine literature has supported. It could take 10 or 15 minutes depending on how that process goes, the style, your own personal communication style, and the style of the interest of the patient. So think a little bit about shared decision making if you haven't already. Maybe take a look at Dr. Blaise's article because this concept is super common when we talk about guidelines. All right, so in 2020, when we put this guideline together, I was asked to speak on the guideline at a few different venues, and I thought about how I could bring this home to what an allergist should do then. And this is the very simple algorithm that we put together that tried to show that the PPI, steroid, and diet options were all reasonable things to start off with and consider. If a patient selected one of these, I was not going to have a major problem and try to steer them into something else. That started with this shared decision making and conversation, and then importantly, after we made that choice, we had to be a little bit more detailed and specify, okay, we're going to select PPI, which drug, which strength, which dosing schedule, how long are we going to go, how are we going to assess response to treatment, before I then decide if that's working well enough to continue on for this patient, or should I switch to some other option here that might be better for that patient. So similarly, if you select diet, there are, as I showed you, many different options of how to go forward with diet, and then making that choice, deciding how it was going to be assessed, and then potentially moving on. I don't know about you all, but in clinical practice, what I often see when I'm getting referrals for patients with EoE is that at one point a decision was made, a treatment was started, and then the follow-up reassessments of that treatment sometimes fall off. And it's important that we make these reassessments because we have several treatment options. Not every treatment option is going to work for every patient, and we may want to switch to another option if they fail the first option. I see patients who try something, it doesn't seem to be working. Either they've continued that indefinitely and then they're seeing me for an opinion, or they've stopped it because they just didn't notice a difference and they kind of went back to sort of their baseline state of disease. So that reassessment piece, I encourage you to be attentive to. Now, since 2020, we have an FDA-approved drug for eosinophilic esophagitis, Dupilimab. It was in our radar as we were thinking about it for 2020. We had just started looking at some of the phase 2 trial after that, and then of course the phase 3 trials have been released, FDA approved, and now Dupilimab is an FDA approved option. So how does Dupilimab fit in to guideline recommendations that we made in 2020? So this is where I think it fits in. We have not formally re-engaged with our guideline group to update our guidelines yet, but likely will be in the near future. So at that first step, there may be a situation where there's a comorbid condition where Dupilimab may be clearly indicated. You probably are familiar with the comorbid indications or the other indications for Dupilimab, which include atopic dermatitis, asthma, nasal polyposis, prurigo nodularis, and may include other conditions as time goes on. But if there is a clear indication, that could be Dupilimab discussing in that first sort of tier of discussion. And then again, specific choices are made. Dupilimab may be considered as a step therapy option where other treatments have been tried but not working. And then again, reassessment with Dupilimab as another option in the mix. A lot of what I incorporated into that algorithm came from a yardstick that Dr. Acivas and colleagues published in Annals of Allergy just last year as a way of trying to integrate Dupilimab's use into our treatment. And these are kind of the baseline summaries from that article. That it could be first line when co-indications exist. It may be best used when other therapies are ineffective or not tolerated. I put this in as a reminder that the Dupilimab trials only enrolled people who were PPI refractory. So it may be selecting people a little bit differently than if we were seeing them for the first time in clinic with a new diagnosis. Maybe the PPI refractory patients are more likely to respond to Dupilimab, and maybe the PPI responsive don't need Dupilimab. I think that's still an open question and maybe a difficult thing to consider as we're sorting through treatment options. And then the fourth bullet point here, I think, is really important. There are no direct comparisons in trials, at least yet, between topical steroids and Dupilimab. This is important because if you read the accompanying editorial to the New England Journal of Medicine's phase 3 trials by Dr. Strawman makes the case that the effect size of topical steroid may be similar to the effect size of Dupilimab. And then it would be, even though the topical steroids, again, are off-label and attempts to achieve a label are ongoing, that the comparison between topical steroids and Dupilimab may be pretty close. But we don't know. More information would be really helpful to help us decide which of these treatments may be favored when we're trying to decide between them. And then the EoE label for Dupilimab, at least right now, likely will change, is 12 years and up. Remember, the asthma indication is 6 years and the atopic dermatitis is 6 months and up. When we go through and do a guideline like this, we identify a lot of areas where we'd really like to have more information to be able to make a more confident recommendation to you all and us in our practice. And so these are some of the things that we identified as future needs. So head-to-head comparison studies between some of these key management choices. There are a few. There are a few head-to-head of a couple of the dietary strategies. There's one head-to-head of PPI and topical steroid that's pretty small, but potentially important. But there's not very many, and having more of these would give us some of the answers that we lack now. And then, as usual, this is a chronic disease. Patients are likely to have these disease for years and years and years, and we're likely to manage these patients for those years. The longer term safety and efficacy and some of those decisions about maintenance therapy are really lacking as far as studies go. And then another thing that came across pretty clearly, and probably no more clearly than in the elemental diet studies, when we looked at the elemental diet studies, we found two groups. One group where the effects of elemental diet were not very strong, and one group where it seemed to be very strong. And it wasn't too hard for us to figure out what those differences were. The ones where it didn't work well were adult patient studies, and the ones where it worked great were children. And of course, the way that the elemental diet was getting delivered and the control over that is different between adult and children. And likely this was a challenge with adults being adherent to such a diet. And so one of the things that's important is to understand these different treatment options and how can we facilitate adherence when we think this is the right treatment for patients and help them overcome barriers. I think you probably also have experienced, similar to me in my clinic, where patients with EoE have come in, they're trying to adhere to a diet. It's hard to adhere to a diet. Many people do not adhere to that diet, and the reason the treatment doesn't work is potentially because they didn't adhere to the treatment. Finally, this concept of shared decision making, at least for now, with the current evidence that we have, I think is important for EoE. And if someone were to develop decision aids that could help inform those discussions, it may be helpful as well. With that, I have now ended the formal slide presentation for the review of the 2020 EoE practice guideline. And